Hi, Malak, can you listen me?
Yes, boss. Good morning.
Okay, thank you so much. बहुत
Ma'am,
दिनों
you are
बाद
live
आपसे
now.
yes, carrying,
Morning,
please.
everybody, and welcome to this webinar of UP State Ophthalmological Society. And this webinar is in continuation with the practice management series. Though today is a topic which is applicable to all, whether you are a private practitioner or you are in a government service, you're working in corporate service, corporate hospital, or you're doing solo practice or group practice, wherever you are. If you're a surgeon, you need this webinar and you need to know the best of practices. So the topic is best operation theater protocols, and this is, as I said, needed by everybody because in today's time, neither can we afford to have an infection, nor do we want to have an infection. For this, the best of people are here with us today to speak on the best operation theater protocols. So before we start, I would request our president, Dr. Malik Chaturvedi, to say a few words, and then we proceed with the webinar.
Yeah. Thank you very much, Dr. Mohita, for arranging such a nice webinar. And I know that you are very proficient in organizing such programs because you keep doing it so many times. As far as the state activity is concerned, this web series was long overdue and it was in demand. I welcome you, all the speakers and all the audience to join in. The purpose is to really reach out to the actual ground level needs of the sterilization. In keeping that into mind, we are starting, and I'm handing over the mic to our secretary, Dr. Mehta.
Thank you so much, dear President. Uh, so um, we have, as I said, the best of speakers, and along with them, we have our very esteemed panel. In our esteemed panel, we have our ex-president, Dr. Dharmendra Nath from Agra. Welcome, Dr. Nath. We have Dr. Shashank from Gorakhpur. He will be soon joining. He's our current president-elect. And we have Dr. Deepak Mishra from Varanasi. Dr. Deepak is our chairman ARC, and again, a dynamic young leader of UPSS. Uh,
Good
so,
morning,
uh,
everyone.
Good morning. So we start with Dr. Matthew Kurian. Thank you, Dr. Matthew, for accepting our invitation. And I wouldn't say coming all the way from Kochi, but talking from all the way from Kochi. Dr. Matthew has done his MBBS from CMC Vellore and his MS and DNP in ophthalmology from St. John's Medical College, Bangalore. And he has done his Ratan Tata Cataract Fellowship from Shankar Nethralaya, Chennai, and he has done advanced management program from IIT Bangalore. He is an assessor of NAPH, so there's going to be a wealth of knowledge that we get to know. And he's the ex-MS and head cataract services of Narayan Nethralaya, Bangalore, and medical superintendent and head cataract services currently at Chaitanya Eye Hospital, uh, Pallari Vatom. So welcome, Dr. Matthew. So you are muted, Dr. Matthew. Can you unmute yourself?
Thank you, ma'am. I'll just start with my screen sharing. Thank you, Dr. Mohita and the entire team from UP for having me in this CME. So we'll be talking about sterilization, and this is in the NABH Eye Care Organization requirements. In the first edition, it is part of the HIC 4D, and in the second edition, which is due to come out now, that will be the core element, which means it is mandatory for everybody to have this at irrespective of the level at which you are operating. So we talk about the requirement for regular validation tests for sterilization, and that it should not just be done, but it should be documented. And this can be done by accepted methods like bacteriological strips, engineering validations like Bowie-Dick. And the WHO recommendations for this is that each load should have the temperature, pressure, and time record chart. The daily monitoring should be for the physical and chemical tests, and the weekly monitoring should be done by the biological tests. So it's desirable to start off with an annual calendar like this for at least the weekly monitoring. So validation is done every 6 monthly. That is the V. And the biological monitoring is done every week. And preferably what we do here is to do it on a Saturday so that we have the report on Monday and no surgery happens after the test is carried out before the report reaches us, and that makes it safe for us. Okay. Now, what is the level of sterilization? This is on the basis of the Spalding's classification. So anything that goes into a body cavity needs to have the benchmark high-level autoclaving, which is steam under pressure. ETO is also acceptable. Plasma sterilization and dry heat are alternatives in this. But for me, the benchmark has always remained autoclaving. Sterilization involves the complete destruction of all forms of microbial life, and the validation is the process of documenting the evidence to demonstrate that the process was done and that all steps were acceptable. So what are the types of autoclaves? We have these kind of vertical small autoclaves, which are actually equivalent to pressure cookers and cannot be validated. The flash or N-class autoclaves are for immediate use steam sterilization, but this is not a routine recommendation for clinical use. It can be used in a situation where a critical instrument becomes unexpectedly unsterile during the procedure and you need to recover it. Horizontal steam sterilizers are gravity displacement, but with a dry cycle can be used safely. But what is recommended is a Class B sterilizer. Class B is typically used for tabletop sterilizers, but horizontal, rectangular or cylindrical high pressure steam sterilizers also meet. They are not called Class B, but they have a separate ISO number. Okay, but equivalent to Class B. So what does this mean? In S class, you have the gravity displacement. There is a dry cycle. That is this one over here. At the end of the steam charge, we have an opportunity to dry that one. B class also has that one. And in addition to the S class, what it does is you have pre-vacuum cycles where the air removal is completed, and this is validated by the Bowie-Dick test. Sort of equivalent thing can be done in the S class by having positive pressure charges, but it is not as effective as having the negative vacuum to remove the air. In validation, what we are trying to do is to monitor that actually what we are hoping to do is actually achieved, and we are looking for a sterilization assurance level of 10 to the -6. That is, probability of survival of an organism should be 1 in a million. And it should be done at installation to assess the routine performance. And this monitoring can be by physical, chemical, or microbiological methods. So in physical monitoring, we are verifying that the cycle parameters have been met. And this is by these kind of digital readings and gauges, which are present on all the devices that we use. It is desirable to have a machine which will give an automatic printout, and these printouts can then be recorded and stored rather than us writing it down. It's a better validation practice to have something which is automatic printed. And this, what we do is validated further by chemical monitoring. And external indicators or type 1 indicators or category C indicators are something like this, which is just to say that a process has happened. Internal indicators are type 3, 4, 5, and 6, and these are called as category I indicators, and it verifies that the sterilizing agent has reached the contents of the package. So this should be inside the pack or set that you're using. But more importantly is special indicators or the type 2 indicators. This includes the Bowie-Dick test, which it confirms that air removal has happened, and batch monitoring strips, which measure that inform that the temperature, steam, and time TST and the air removal has been completed. So here we have the internal indicator sitting there, and this is for pack control because it gives only one critical variable has been achieved. Class 4 is showing that more than one critical variable, and class 5 and 6 integrating and emulating show that TST, temperature, steam time, all have been achieved, and these are used for pack control. So what is monitored by these chemical indicators? Temperature, steam time, and for ETO, gas concentration, temperature, humidity, and the exposure duration. In autoclaving, the classical Bowie-Dick is this layers of cloth where you put the large sheet, which is yellow in color when it is unprocessed, and when it is passing this process, it will become all black, and a failure would be indicated by a little bit of black, and the rest of it is still yellow. But that is a little more cumbersome. And what we do now is to have this kind of a Bowie-Dick process challenge device. We do it every day in the empty chamber of the autoclave before the first process load for that day. And this is the Bowie-Dick strip. It is all yellow when it is unprocessed. And we keep it for the temperature 132 degrees to 134 degrees for a duration of 3.5 to 4 minutes. And by the end of that cycle, when we remove that, it should have changed from yellow to black. So it is much more, just place it at the bottom of the autoclave, empty load. And then at the end, once it is cooled down, we can take it out and it should be changed all to black. If this has changed to black, then only we should do our load for the day. And you can see that this is all black, and then it is safe to proceed for the day. This is a typical pack that we use. That is a cataract set. One single pack is adequate if it is used the same day. Double packing can be used. And along with that, for each batch, we have the off-the process challenge device with a batch monitoring strip. That is the monitoring strip, blue in color when it is not exposed, black after it has been exposed. And this is the process challenge device, which is the off-the PCD. And this is a cross section, yellow when it is not exposed. And along with the batch, once the entire batch process cycle dry is complete, we have to take it out and check that all these yellow squares have become black in color. If that has become black in color, then it is okay to process that, use those instruments. So this is fine and ready to use. This is how this is recorded. So this is what we do, but recording of what we do is a more important thing. And here we have the digital printout. We have the batch monitoring strips, which is the class 2 indicators. And here we have the external process indicators, and this is done for each batch. And what all goes into that batch is documented at the bottom. Now, patient-wise, for traceability, we have the internal indicators and the external indicators. So we know when it was done, who was the person who processed it, and all the details are available with us. Now, unfortunately, the chemical indicator does not tell if the load is completely sterile. It tells you that at the location where the chemical indicator was placed, it is okay. A biological indicator it needs to be placed inside along with this at the place where the load is most difficult to sterilize. And this is also done in the process challenge device. So recommended frequency is daily for sterilization, but at least minimum weekly. That is what the NABH recommends. And for gas sterilization with every load. So rapid biological indicators are available, which are equivalent to the full cultured report. Ideally, what you should do is load this inside the process challenge device, the change of color will indicate that this rapid report is acceptable, but the solution at the bottom of the tube needs to go into the incubator, and at the end of incubation, we need to ideally get a report which will say that there was no culture. And this is again documented, biological indicator, what was the change in color, the batch details, process device, that is for both steam and ETO are kept like this. The biological indicator is Geobacillus steatothermophilus for steam and Bacillus atrophius for ETO. And the culture report is also kept, and this will show that no growth observed after 48 hours of incubation, and then we are safe to proceed. Now, what happens if the dry cycle is incomplete? This kind of a thing is not acceptable, and this is called as a recall procedure, which is HIC 4E. And is the test okay? It should be documented as not okay. And in such a kind of situation, we should stop the sterilizer use, report to the company, repeat the biological indicator in 3 cycles. And if it is any of these are positive, then we should recall all the items since the last negative biological indicator. We should check the sterilizer settings, check everything is correct. And then if we get 3 consecutive biological indicator cycles as negative, then we can start the use of the sterilizer. The validation of these things is very critical, and it's better to get it done by an external agency. NABH requires it 6 monthly, and what is tested is to see whether what is achieved is what is set in terms of temperature, steam, time, and vacuum. And functional validation can be done by the helix or the heat penetration resistance test. So here inside the chamber at 9 points, this kind of resistors are placed, and the thermal calibration is performed. This is for the ETO, and this is for the steam sterilizer. And this is the functional validation, the heat penetration resistance test. These long tubes, which give different resistance to heat and steam penetration, have opening at one end, and the indicator is placed at the other end. So this one will tell you what is the diameter of the tube and what is the length of the tube, and that will has a calculation to show you how much of resistance to heat penetration is there. And if it all becomes black, then these are the pass conditions, and we can have for increasing resistance, and at least we should have HPR, which is okay for greater than the longest tube that is going to go into the autoclave. And fail conditions will be like this, where the black is not formed, it is a light brownish one, and in which case the sterilizer needs to be stopped and needs to be serviced. Internal audit, we need to check all these things, and it is available as an app, or you can keep it on a hard copy. And in conclusion, validation confirms that the sterilization process is acceptable. It can be done by physical, chemical, and biological indicators, and the documentation helps the traceability in the event of any breach of process and protects you from medico-legal issues. Thank you for your attention.
Thank you so much, Dr. Matthew. This was very, very informative. And I would like to ask you a question.
Sure.
In today's time, I think most of practitioners would still be using either horizontal or maybe a vertical also autoclaves. So do you think it's an era where we should do away with these autoclaves?
Yes. So the horizontal autoclaves, it can be validated just like a Class B sterilizer. But the person who is operating that horizontal autoclave should be trained such that the positive pressure charges are put in 3 or 4 pulses at the beginning of the cycle, and we are able to have the physical validation as well as the chemical indicator validation once in 6 months on the Helix test, in which case the horizontal thing performance wise is good enough. But if we have a automated class B sterilizer or one of those larger horizontal autoclaves, the documentation is automatic. Allegations of manipulation of the result can be avoided, and it makes it much more secure for the practitioner. Cost-wise, these things are not at all expensive. And in terms of blood pressure for the practitioner, it really, really reduces the blood pressure.
I think so much we invest on equipment, but many a times we just forget to invest on autoclaves. So it is a time, the message is clear. It is a time that we have to start investing on our autoclaves as well as knowing all the procedures ourselves before, even before our CSST staff. Then only we will be able to check if everything is okay or not. Dr. Shashank Kumar sir has also joined us. So would you like to give a few comments on um, horizontal autoclaves versus the various other class autoclaves? You are muted, sir. You are muted. Can you unmute yourself?
Good
Yeah.
morning, ma'am.
Good morning.
Sorry about that. I am using the vertical one and horizontal one both. And I am much more comfortable with the horizontal one. And I do regular checkup by the autoclave indicator. And I think this is good. I think everyone should use these indicators for the safety of the patient and to make sterile surgery.
Dr. Nath, would you like to give some comments on the talk? Anything you want to? Please unmute yourself. Please unmute yourself, Dr. Dharmendra Nath.
Is it okay now?
Yeah. Yeah, it's
Can you
okay
listen
now.
me?
Yes, I
Uh,
can.
So in our practice regularly we are using the horizontal ones and the ETO with my friend, because they have a big hospital. So sometimes our disposables where we don't want to use so much of the ETO, we send our equipment to the ETO, the full packs, and get them back to us. So this is one way we use the ETO with the courtesy of my friend, and we use the horizontal autoclavers. And they are very good and convenient to us, to my staff, and the autoclavers should be very much comfortable to the staff also. They should know all the technique behind this, the how to use this equipment, when to use, and how much pressure has to be maintained, how much temperature should be maintained, and how it has to be logged. Everything should be properly, and then you are at ease, because most of the time you are not going to see them.
Yes. So Dr. Matthew has told us many new things, and I'm sure all of us would like to incorporate those new things, because I'm sure we are only doing 50% of the things. And after his talk,
Yes.
we would try to reach 80 to 90%, if not 100%. Dr. Malay sir, your
Ma'am.
comment, and then because this is a very, very important talk, and then after that we go on to the next presentation.
If there's a minute, ma'am, I also had a question after
Yes.
Malay sir. I can put it
Yes.
across.
Yes.
So basically, my take on this subject is that what has been told by Kurian sir is the ideal situation. And horizontal autoclaves are better than vertical autoclaves. Steam autoclaves have been replaced by B-class autoclaves. But if we
Yes.
are using the protocols and if we are monitoring things carefully, then whatever autoclave we have should work as good as any other autoclave, provided we are careful and we are dividing the sessions. That's my take.
so much. Yeah, Varun, you wanted to ask something?
Very briefly, sir, a lot of us don't really understand what technical differences the different class of the autoclaves have. I don't know if we have enough time. Could you just explain to us? And is there a particular class, a minimum requirement that the NABH requires? Because almost 90+% of doctors use the vertical steam autoclave, which can accommodate up to 2 to 3 drums. How far off from the requirement are we?
See, in the vertical autoclave, what happens is steam comes in, steam rises to the top of the autoclave, and there will be an opening at the bottom which lets the air go out and the water to drip out. But vertical autoclaves typically do not have the capability of a dry cycle at the end of the process. So all the equipment that comes out will be wet, and these are not capable of being stored anywhere. So if you are having a vertical autoclave, it must be for immediate use. So today there is a case, you autoclave it, take it out, and immediately you use it. That is fine. But a horizontal autoclave or a Class B autoclave, two advantages it has. One, if you have those negative vacuum cycles at the beginning of the process, you are pulling air from inside the chamber. Complete air removal is necessary for steam penetration, especially through hollows. So if there is a cannula, a phaco tubing that is to be reused, all those things need to have the complete removal of air from within the tubing. And without the negative pressure at the beginning, it is not possible to displace that non-condensable gas. Second, you want a completely dry item at the end of the cycle, so that irrespective of whether you use it now or a day later or 2 days later, the pack continues to remain sterile. If there is a moisture, you take it out of the autoclave, the wetness on the pack will cause the packing to become unsterile, and whatever surface you're placing it on, there will be some organisms or a possibility of organism there. Those organisms come into the pack, and then you are using a unsterile equipment at the end of it. So complete dry at the end and negative vacuum at the beginning, which will help to ensure that all the air is removed. These are the two critical items. Class B is the one that meets it, and the large horizontal sterilizer also meets it. Thank you.
Thank you, sir.
So very important message from Malay sir that monitoring is very important, and very important message again from Dr. Matthew that
Could I just add
that
one more point?
yes.
As with respect to the B class, there's also the printout. And I found that this was as important as having a B class autoclave, because in our scenario, what was happening was we got two new probes. We were using it in a B class autoclave. There were no error codes, but the probes kept getting short. So when we looked at the printout, we realized that during the dry cycle, the temperature was rising up to 242 degrees Celsius, even though we had set the limit as 134 for 7 minutes. So this was a finding that was quite shocking to us, because the autoclave showed no error codes. And just based on this, we could figure out that this is the problem. And then we had to call the person and get it repaired. So having a printout really helps you monitor even and protect your own equipment.
Shantanu, this is exactly a situation which we faced recently in the beginning of this year, where two of our probes actually got spoiled in a similar manner, and we could not identify. We thought that something was wrong in our OT. Why the tubings only got kind of melted, and even the company people were surprised as to how the tubings melted, and one of them was almost a new probe. And when we could not identify it ourselves, but when we called the company from persons from the autoclave, they said your temperatures are going very high. So this is something which was a new this thing. So it is very good that you shared here. So now we go on to Dr. Shantanu Gulati, you yourself. Dr. Shantanu is a young UPSOS member. He's a fellow in cataract and glaucoma surgery at Sivanand Mission Trust Eye Hospital, Viratnagar. He has a keen interest in ophthalmic infrastructure design, modular OT setup, and sterilization protocols, and has been actively involved in a 3-month OT overhaul. So he's actually the right person to tell us about the best protocols for or best features of a modular OT. Over to you.
Is my screen visible?
Yes, it's visible.
So hi everyone, I'm Dr. Shantanu Gulati. At the very outset, I'd like to thank Dr. Mohita for this opportunity. And I'll be presenting on the modular OT features that help prevent endophthalmitis and infection in ophthalmic OTs. So a modular operation theater is a prefabricated structure which is designed with seamless and non-porous surfaces, hermetically sealed doors, and a dedicated air handling unit. What is important is that all these components should follow certain standards, such as the ISO 14644 standard for your surface and the ASHRAE standards for the air handling system. So starting with the wall panels, this vendor BOM code shows that it is comprised of 4 parts. The first being the wall panel itself. The second being your antibacterial paint, which is utilized in certain walls. Then the aluminium coving and the anodized corners. So with respect to the wall panels, there are various options available in the market. It can be available as pressure laminates such as HPL or galvanized iron panels. These galvanized iron or GI panels, as they are commonly said, can be pre-painted or they can be epoxy coated. So that is known as EGP or PPGI. And obviously there's the well-known stainless steel 304 option. So what is important here is that most of these are available as sandwich panels. What that means is between 2 surfaces of the same panel, they'll put a certain density of PUF or polyurethane foam, which provides the thermal and the sound insulation that is required. So with respect to the infection control features, these panels are modular, so they can be fit quite fast as compared to a brick system. They are seamless, they are non-porous, they are treated and certified for antimicrobial activity, they are resistant to repeated cleaning, and they provide thermal and sound insulation. So what you see here is an image of a PPGI panel. The image on the top is the front surface, which is showing the smooth non-porous characteristic. And at the behind, in the lowermost image, you can see the GI panel. Also, your vendor should be able to provide test reports that are often asked for by the NABH or the government people when you start your OT. The materials are tested in various agars and then they are shown to have the antimicrobial, antifungal or antiviral properties. Now, practically speaking, there are various limitations. Although these panels might be the best available option, but practically there are various limitations because each panel is 4 feet in width and 10 feet, around 10 feet in height. So after every 4 feet, you will have between 2 panels a 10 feet high crevice. So now that crevice has to be filled up with silicone and heated. So if this is not done well, then the silicone will protrude outside and you will create a new crevice. So that will make the whole point of this moot. The same goes for coving. As you can see in the image on top, the coving has been applied, which is meant to make the 90-degree corners smooth so that you can clean it properly. And there are no surfaces where your mop doesn't reach. But as you can make out here, a new crevice has been created, which is visible, and then this has to be fixed again. So my point here is that this is not a fit and forget system. You need excellent craftsmanship and you need to monitor the whole process. Again, this was the HPL panel which delaminated within 3 months of installation. As you can see the bulge here, and then it had to be replaced. So now another feature of the wall panel are pass boxes. So pass boxes are normally made of SS304 and there are doors on each side which are electronically controlled. So if one door is open, the other won't. And on the inside, there will be most commonly a UV lighting. This is called a static pass box. There are also dynamic systems which have the HVAC input. So they help preserve the zonal integrity and they help maintain the unidirectional flow. So coming to the next thing, that is the flooring. So OT flooring has to follow the same surface standards as your walls. The options that are most commonly available are epoxy and vinyl, of which epoxy gives a more seamless finish, but it takes much longer to install and it is more cumbersome to repair. So the vinyl option comes in prefabricated rolls that are placed onto a prepped surface with industrial adhesive, and whatever joints are created are then welded together, making it seamless. So even the patchwork here is easier because the patch requiring the patchwork can be just cut out and replaced. So now another thing that I found out was that the vinyl can be conductive and non-conductive. So basically what conductive vinyl means is that it has copper wires or carbon chips that are connected to the grounding of your OT. What this does, it helps prevent accumulation of static electricity, and therefore your sensitive devices such as the phaco machine are kept safe. So, but these are considerably more expensive, about 3 times compared to your non-conductive options. So in the general OT complex, we can use non-conductive vinyl, but inside the OT complex, conductive is a requirement. The next feature is hermetically sealed doors, which follow the same surface standards. But the point here is that because of the hermetic seal, they prevent loss of positive pressure, and they also prevent air ingress from outside to inside. Apart from this, they are also available as touchless automated options, which further help maintain sterilization. So what you see here is a drop down seal. When the door is closed, the pin that is visible goes inside and the seal drops down, making the OT room hermetically sealed. But what is important is that, as you can see in the image which is shown on the lower section, there was a crevice in the flooring itself. So that again, the hermetic door will not help if your floor is not perfectly leveled. So the doors again are available in various options and we can choose as per our requirement. Now the OT ceilings are again with respect to the surface, they follow the same concept. What is very important here is the laminar flow pallinium. So this is the stainless steel pallinium that is shown above the operation theatre table, which from which the filtered air of the AHU comes directly onto the operation theatre in a laminar fashion. So what is important is the size. It has to cover the patient's head up to the torso. It has to cover the surgeon and 2 to 2.5 feet on either side of the OT table, so that your instrument sets, when they are opened from the sterile boxes, they are opened below the pallinium, which is why, as you can see in the image, the vinyl right below the pallinium is of a different color, so that your staff knows whether they are under the laminar flow or not. This is an image that is showing the flow from the AHU onto the table. Then the air goes back from the return riser again into the AHU. A very practical point here is about the height of the operation theatre. So you have to provide your vendor with a minimum height of 12 feet. So we did not have that here, as you can see, because of the beams, which is why our ducting came below the 9 feet level. This is not recommended because for the floor to be laminar, the height of the laminar pallinium has to be at least 9 feet from the floor. And this also affects the seamlessness. So to prevent that, you can either plan to not have a beam in the area where you're planning the OT, or you can have inverted beams that are present on the roof and not inside. So this is just an image that we had to cut the beam here to fit the OT ceiling. Now coming to the HVAC system, this is the heating, ventilation and air conditioning system, and this is perhaps at the heart of a modular OT. So what this does is it takes the air from inside the operation theatre, mixes it with fresh air from outside, runs it through various filters of specifications that I'll be talking about later, cools the air using an air conditioning unit, and then pushes that air with a certain pressure inside the operation theatre. So again, using this bomb, we'll see that what the HVAC is comprised of. The first thing is the pallinium, which is of various sizes. As mentioned, it can be 6 by 6 or 8 by 4, whatever you can plan. Then the air handling unit, which has a CFM value, which again I'll be talking about. It has a condensing unit, which, as you see here, is mentioned as 5.5 twin or 5.5 plus 3 ton. So there are basically 2 condensing units, so that if one fails, the other keeps on functioning and you don't have to stop OT. And also in India, in some places, about 8 ton is actually required to keep the temperature in the required standard. So with respect to the NABH 2018 revised guidelines for air conditioning in operating theaters, the modular operation theater is not a mandatory requirement. So basically whatever panels I talked about are not mandatory. What if you can arrange a system which is seamless and non-porous and maintain it, that is acceptable, whether it is done by vitrified tiles with grouting or a punched surface with paint application, which is antibacterial. With respect to the air management, AHU and HVAC systems are recommended even if you are doing a pre-entry certification standard. There it is not compulsory, but it is still recommended. So there are various air parameters such as the air changes per hour have to be 20 with 4 fresh changes. The positive pressure has to be about 2.5 Pascal, whether in the operation or non-operational hours, and temperature and humidity standards. Various HEPA filters of efficiency 99.97% down to 0.3 microns have to be installed. And the air supply at the grill level, at the level of the plenum, has to be ISO class 6. So I would just like to talk a moment about the CFM. So if your room size of the OT is suppose 15 feet by 15 feet and a 10 feet height, that makes the volume of air inside your room to be around 2300 cubic feet. And if I'm saying that there are 25 air changes required per hour, that means your AHU has to push 25 times that volume, which is around 57,000 cubic feet. So the volume of air that has to be pushed per minute means that you divide this value by 60 and you get the CFM. So what you'll see is that a required CFM is around 1000, but generally the vendors are providing 2 to 3 times this capacity for the AHU. So this is what the CFM means when your vendor talks about it. With respect to the design, before calling a vendor, you have to be sure where you will want to place your OT tables, because the plenums and all the ducting has to be designed around it. So it has to be decided whether you want one table that will move around if you do temporal cases, or you will have 2 tables and you will be the one moving around with within the tables. So also your vendor should be able to provide regular validation and monitoring, which is required for compliance with NABH. So at the moment you start your OT, and about every 6 months we get our AHU validated. As can be seen here at the level of the grill, it is ISO class 5, which is a class above the requirement, which is ISO class 6. Also for validation and monitoring, there are surgeon panels. So what you see here on the bottom right is the most basic one. And as you go above it, they become more expensive. This is on the left is the membrane panel, and on top is the Android unit. So the only advantage with the Android unit is that it stores all the data. So you don't have to log the pressure or the temperature or the humidity manually. Thank you.
Very informative talk. Thank you so much, Varun, for enlightening us with the minutest of details related to modular OTs. And we all know that whenever we are planning a modular OT, we are calling up here, there, our colleagues to understand what everything means. So you have simplified it so well. So there are some questions which have come on the link where the questions are coming. So I just want to ask a few which have come up. One is which is the out of all the wall panels, etc., which is the one which requires minimum maintenance?
So there is no panel which will not require a maintenance. They each have pros and cons. The HPL looks the most aesthetic but can delaminate. With respect to PPGI, it's more easier to scratch because it has a very metallic finish. So if your any tray touches it, it gets scratched easily. So you don't have to think that this is fit and forget. They will require maintenance no matter what you choose.
So maintenance is a must.
Yeah.
So another question that has come up is that if we have this AHU and laminar flow, etc., can we fumigate that OT? Does that affect the laminar this thing? Because the person has asked that if sometimes if the AHU or the laminar is not working, and in that situation we have to fumigate, can we do that or not?
So what they ideally say is that your AHU should be running even in the non-operational hours. So if you have a unit like that with a VFD device that basically switches off the air conditioning to minimize your electricity bills, but the AHU keeps running at a reduced cycle, then you don't need to fumigate. But if you have a system without this, where you have, and you are turning it off in the non-operational hours, then we were provided with covers that we applied over the Pallinium and the return air risers. So the fumigated air did not enter the filters. So you can ask for that from your vendor.
So there are covers to cover it up if you want, if you have to do it. So, Dr. Malay sir, would you like to make any comments on this?
This presentation is fantastic, and I think we should have people like him on our continuous support system. Suppose if somebody wants to go and have a modular OT, then we will take help of people like Shantanu and Dr. Kurian. But the message which seems to percolate is that if you do not have a modular OT, then you are unsafe. That message is not good, because 9.5 or 10 people will not have a modular OT. And we have to really come out with things which should work on ground without going high tech. Going high tech increases the sensitivity and specificity. It make you more powerful, but definitely as a society, we should look out into more effective protocols which are working on ground, which may not be of NOBHS standards, but which should be working. That is my take.
So as Dr. Malay sir said that, yeah, Dr. Matthew, you wanted to say something?
Yeah. So NABH's requirement from the point of view of documenting that your AHU is working properly or your air quality is acceptable is that there should be a daily log of temperature, relative humidity, and pressure. So positive pressure is required. The temperature should be between 21 to 24 degrees centigrade, and the relative humidity should be maintained during operational hours at least between 45 and 55% RH. And this we should have the daily log. The validation typically by an external agency should document that we have more than 20 air changes per hour at least. And that is actually a calculation. And the recirculation of air should be not more than 80%. So each cycle, if we are having recirculation to reduce the energy costs, should be at least 1 in 4 should be fresh air. And we look at the efficiency of the filter. So 3 things basically happen on the filter. One, the filter itself can get choked, in which case the air velocity across that filter will drop down and the air changes per hour will become less. Or the filter will have a hole, in which case the particle count in the validation will show that there is a problem. So these two will show whether the filter itself is okay. But more importantly, what happens is the fitment around the filter onto the plenum can be leaky. And there, that test is what is called as a bypass leakage test, or it is done by a chemical called polyalpha olefin, PAO test. And between particle count, air velocity, which is measured, air changes per hour, which is calculated, and bypass leakage, which is again measured, we can confirm that the equipment is doing the job it is designed to do. It is also desirable to do microbiological surveillance using either a settle plate method or an air sampler, especially when you have commissioned the OT new, or when you have an outbreak and you want to see whether there is a problem. It not necessary to do air surface and water cultures on a regular basis, but it is desirable to do it. And some of the assessors and some of the state guidelines ask for microbiological surveillance as well. So it's safer from our side if we do that.
Thank you so much. So as Dr. Malay sir said, we want you to be available for supporting our members. And Dr. Shantanu, though he's in Gujarat currently, but he belongs to UP, and he's also the son of Dr. Gulati from Jhansi. So I'm sure you are coming back soon to UP. But till then, we could, with the permission of the president, we will discuss this later, and we could make a committee which could be kind of a support group for within this practice management wing of UPSOS. And this support group could help anybody who wants to design new OTs or want to revamp their current OTs.
Definitely.
And now we go on to our very own president, Dr. Malay Chaturvedi, who will give us very practical tips about instrument and equipment maintenance. Again, a very, very important topic. And this is also very important to prevent, not just to maintain them for a better performance, but also to prevent infection.
Thank you. I will share my screen. And I think it is now shared. Can you see the screen?
Yes, we can.
Okay, thank you. That's great. So basically, this is the photograph taken in the summers of the river Ganges in Kanpur, where you see there are dry patches. And I named this photograph as trabecular meshwork because it was almost looking like various parts of the trabeculae. Now, the purpose of this presentation is to show you how we could achieve complication-free cataract surgery over a period of more than 2 decades. It may not fit into the classical description of the book, but ultimately it seems to work. There is a need to understand that what is working should not be ignored. In fact, the dictum is that winning combinations should not be disturbed. The ultimate aim is to empower the common practitioner, which in our cases are mostly proprietors. So here is the first video, which is showing how we are cleaning our tubings. So here is the next video of how we are taking care of cannula.
Dr. Malay, we are not getting the sound of yours.
Yeah.
We are not getting the sound of yours.
So then should I,
We can hear
should
now.
I-
We can hear now. Now we can hear. In between
now you
the
can
sound.
hear?
Yes.
So, can you listen to this?
No.
Yes, yes. We can hear your sound.
So basically what I'm showing here is that where ultrasonic cleaning is not possible, we'll do physical cleaning. Just wash. Now, once so basically, the entire purpose of this instrument cleaning was to show that after each surgery, the amount of time which we are doing in preparation of the surgery or doing the surgery, we should give enough time to finish up after the surgery or the post-operative, post-surgery care. Now, most of the surgeons who are individual surgeons and who are not into an institution, they do not do more than 4 or 5 surgeries a day. Suppose if we do it like this, then we can do up to 100, 120 surgeries a month. That should cover almost 80-85 percentile of the individual surgeons. So the trick is in dividing the surgery. After doing each OT, we should be giving time in OT maintenance. Most importantly, it is not only the structure which is important, but it is the technique which is more important. For example, if all retina guys would understand what did we learn in our fellowship and what we called as no-touch techniques. In fact, in COVID time, the entire country understood what is no-touch technique. And we could see active COVID patients on a slit line. Although the viral load was there, but was not getting transferred. So if we understand the key points or key source of infection, for example, our air conditioning thing, our autoclaving thing, and there are other critical areas from where you tend to get end-off. And we should also understand that purpose of sterilization is not to make it zero bacteria or zero microbe, but to reduce the microbial load beyond a particular thing. And if we do our patient preparation well, and if we take care of the no-touch techniques, and if the God is not against you, then most probably you are selling in the right course. Thank you very much. And this is the photograph on the left side, which we took a couple of days back after the rains started, and I wrote this poem. Thank you.
Thank you so much. You are reading your poem, beautiful poem. I've captured it also in a click for others also to see. So, एक बार poem हमें सुना भी दीजिए for the audience.
जो भीगी सी शाम ढली, उजली सी एक सुबह खिली, बादल ने डाल दिया डेरा। टिप टिप की थाप पर, बुलबुल की राग पर, इठलाती बेलों पर, बारिश की बूंदों संग, मेघों के मल्हार पर, पल खाती लहरों संग, हल्की फुहार सा नाच उठा मानो।
Wonderful, beautiful, beautiful. In the middle of all the SSI protocols and all the infections, this is like a very, very
Malay,
quiet
Some different. हाँ बस
भले
हाँ बस
आपने बहुत बढ़िया पॉइंट कही, परंतु ऐसा लगा जैसे सुमित्रा नंदन पंत कभी गा रहे हो किसी जगह हिंदी में, इतनी बढ़िया पॉइंट वो भी किया है। So, Dr.
Yeah.
Bhatt, I just want to ask some few questions from you regarding the
Yes.
instrument cleaning. May I
Yes.
ask you?
Yes, please.
अगर
I
क्या
am expecting
इंस्ट्रूमेंट को
questions.
आप नहीं, क्या आप अपने इंस्ट्रूमेंट को धोने के बाद में इनको ड्राई भी करते हैं बाय द ड्रायर और नॉट?
सर ऐसा है कि ड्राई करना चाहिए और उसके लिए अगर ड्रायर हो तो बहुत अच्छा है. इनफैक्ट वी वर थिंकिंग कि वी शुड हैव अ ड्रायर, बट इफ यू डू नॉट हैव अ ड्रायर इन अवर पार्ट ऑफ द कंट्री ऑलरेडी, except for these rainy seasons, things are quite dry. Just keep it there, it dries out. Or a simple fan is also good enough.
जो लेडीज यूजुअली यूज करती है हेयर ड्रायर, आई थिंक दैट कैन सर्व द पर्पस. नंबर वन,
Yes,
इफ ड्राई
yes,
the instrument, there is a less chance of the rusting.
yes. So dryer is a very good option. We were thinking कि क्या करें. आपने आइडिया दे दिया है कि हेयर ड्रायर को यूज कर लो, ये बहुत अच्छा है.
So
That's a
I
very
have
good
a
question.
question.
Secondly, I just to enumerate one thing, that whenever you use water, try to use the less salt water. It means you can use about this Kent water or whatever is this, not the tap water, regular water, because that has more the salts on it, and that gives a chemical reaction on the instruments, and it is better to use a low salt density water.
Yeah, so basically, it's a very good suggestion, Dr. Dharmen. I am a great fan of you, and we have done together so many changes and innovation in phaco surgery, you know. The easiest thing would be to use a 0B or a filter water because it is available widely.
Yes.
Yes,
And
very
keep
good.
always keep that, the record of the water, see how much the salt density is there. If it is very low, 5% or 3, then that is a wonderful thing, and make your instrument very safe.
And Dr. Dharmen, you will be surprised that for last almost 2 years,
Yes.
I've stopped washing my hands before surgery. I have stopped washing my hands before surgery. I do not wash my hands.
Then how to do the surgery without washing the hands?
We follow no touch techniques.
Okay.
So if you understand no touch technique, just have a cup of coffee and put your gloves inside the hand. Put your hand inside the gloves and start operating. Infection will not occur.
Definitely, because that is no touch technique. So ultimately, your assistant should provide you the gloves.
Which is very easy to make him.
Yes.
If he can handle the monitoring of such a complicated OT system, making me understand to how to make you wear gloves is very easy in comparison to that.
I have a question with the Satansu. May I ask a small question?
Yes.
How much do we require the minimum OT dimension? Minimum OT dimension should be.
Shantanu, yeah.
Yeah. So there is a recommendation which is present in the NABH 2018 guideline, which says 20 by 20. But I'm sure most of us don't have that much space available. So what I can tell you is that if you want 2 operation tables, what minimum you require is around 15 by 15, because the OT table itself will take around 2.5 feet, and then you need 3 to 3.5 feet on each side. So if you have a dimension of 15 by 15, you are very comfortable with one surgeon. You can't have 2 surgeons. So if the single person is switching from table 1 to table 2, then 15 by 15 is very comfortable. If you plan to have 2 surgeons inside the OT, then it should be a little bit more.
But according to AIOS protocol, AIOS recommendation, there is 160 square feet should be the floor area. 160 for 4 people. What they recommend?
Yeah, but I mean, this is from my practical experience. I have seen where I am working, there are OTs ranging from 12 by 12 to 25 by 25. And the most comfortable size that we figured out is 15 by 15. It saves the most amount of space, and
15 by 15 means 225.
yes.
So with this, we go on to the next talk of what we do immediately after if we discover a surgical site infection. So can you all see my screen?
Yeah, we can see surgical site infection. We can.
So we followed all OT protocols and we had the best of modular OTs, and yet we could find any of us could find that we landed up with this situation. So, and this is what we all fear, that on our post-op day 1 or post-op day 3 or 4, the patient comes up with such a situation. So immediately what do we do is what I will talk about once we see such a situation. So the immediate steps have to be, we inform the hospital infection control committee of the incidence of infection. And in hospital infection control committee usually has a chair who's the medical director or the head of the hospital. There is a secretary who's also the infection control officer, and there are members which include OT representative. If there is a microbiologist, then a microbiologist, nursing staff, pharmacist, CSSD member, and clinician. So it is ideal to cancel and all future surgeries, because we have to look into what the source of infection was in our operation theater, and we should contact all the surgical patients of the same day which were operated either on the same day, or even if suppose the patient came after 1 week, then within the week after, in the days after this surgical, when this surgery was performed, those patients should also be contacted. The procedure is that the medical director or the head of the infection control committee informs. Medical director is the one who authorizes the sealing of the operation theater, authorizes cancellation of all surgeries, and instructs the OT staff to initiate the SSI protocol. The OT in charge seals the operation theater and sets the recall procedure in practice. And this is what needs to be done. You have to make a list of patients who underwent the surgery on the date of the infection from the OT register. The list is given to the center head for the patients to be called to check on their status. All the patients of that day who were operated that day should ideally be called for an examination to rule out any infection. And even if they are not able to come for some reason, a call should go to them to ask about their well-being of their eye. The chemical indicator of the infected patient is marked in the OT register, and all the indicators need to be checked, which were put in the autoclaves or ETO on that day. The batch number of the consumables of the infected patient should have been noted down. In fact, it should be a practice to note down the batch number of the consumables that are used in every surgery, and the manufacturer of the consumable should be informed. And simultaneously, cultures need to be sent not only from the OT, but from these consumables also, from the same batch number. And ideally, we should remove that batch from that batch from our operation theater, and procure new batches of all intraocular fluids. Culture reports, as I said, should be sent, and the last indicators should all be assessed. A terminal cleaning of OT needs to be done, and pre and post terminal cleaning, swab, sedimentation plates have to be seen for the culture sensitivity. And only when the reports, at least 2 reports, ideally show no growth, then further surgeries to be posted. And if the report shows that there is a growth, terminal cleaning needs to be done again till the report shows that there is a nil growth. So this is what needs to be followed. And now, before you restart your OT, is always when you have some goosebumps and you are scared that this infection may be an OT infection, and hence you may have further such cases. So what is it that you could do to when you actually get started? You could do a double autoclave, you could do a double sterilization, and you could use only new batch consumables. You avoid any ETO items, because autoclaving is always superior to ETO, as Dr. Matthew also just said. No disposables to be reused. Ideally, we could do a revalidation of the autoclave as well as ETO, because that may be the source. A HEPA filter revalidation may or may not be done. Ideally, it is Dr. Matthew will be able to tell us better, but 3 to 6 months is what is followed. So water culture report may be taken, and we can start with an extraocular cases. And of course, we should not have a long OT suddenly. When we restart, we should start with less number of cases, maybe 1 or 2 cases, and then go on, see the result, and then go on to more number of cases. So this is all about my presentation. I wanted to keep it short and practical, and something which everybody could follow in their own setups also. And this is what we normally follow. So anybody, if you have any, Dr. Malay, would you like to give any comment? Anything different that you would suggest?
I can just say that this was a very good program. We had people from both extremes, one on the top and one on the bottom ground.
We have one more talk left.
So we will continue with that.
Yeah. So what I meant was, anything that I have just spoken about, you want to add on anything, or you think that is complete?
I think that is very, very comprehensive.
Okay, thank you. And so our last talk of today by Dr. Varun Kharbanda, and it is on intracameral antibiotics, truth or hype. Now this is again a controversial topic, and we all are still thinking as to whether to use or not use. And whenever there is a survey on whether these should be used or not used, there is always a divided house on whether to use or not. So Dr. Varun, let me just introduce you. Yeah, let me just introduce you before you start.
Sure, ma'am.
So Dr. Varun Kharbanda is the head of the department in cataract and refractive surgery at Mahesh Netralaya, Prayagraj. He's a chief consultant at Netralaya, Prayagraj. He has done fellowship in phaco and refractive surgery from Narayan Netralaya, Bangalore, and he's an ex-consultant and phaco trainer again at Narayan Netralaya, Bangalore. He has researched and published on various subjects like applications of microscope, integrated real-time ASOCT in cataract surgery, pupillodynamics in Indian population and its application in toric IOLs, refining refractive outcomes post-cataract surgeries, especially in post-refractive surgery patients. And his chief areas of interest include phaco training and refractive lens surgeries. Over to you, Dr. Varun.
Thank you, ma'am. Is my screen visible to everyone?
Yes.
I would like to thank Mohita ma'am and UPSOS at the onset for giving me this opportunity. I'm Varun, and I'm going to be talking about the use of intracameral antibiotics, truth or hype. I would like to begin with showing a routine, uneventful cataract surgery to share what goes on in the mind of a cataract surgeon when he's actually doing the surgery. Most of us, by the time we do the first crack, are already thinking about a smiling, happy patient with a clear cornea the following day. As we keep chopping more, we think more about iski dusri aankh ka operation kab karna hai, when do we plan the other eye, and so on. By the time the surgery is over, you're actually quite pleased with yourself and patting yourself in the back for being such a wonderful surgeon. Unfortunately, sometimes that world comes crashing down when the following day you see this. This, ladies and gentlemen, is endophthalmitis. It's every ophthalmologist's worst nightmare. And apart from the actual surgery, almost everything that we do is towards preventing this complication. Things like proper OT, sterilization, cleaning, etc. And in the same series of events, we have the use of intracameral antibiotics, which is what we're going to be talking about today. Some disclosures: I have no financial interests, and as of today, I do not use intracameral antibiotics, but we will get to that a little later. So how did it all begin? It actually began as early as 1977 when Payman et al. Published their series of about 1600 cases in a South Indian eye camp. And they reported the reduction in endophthalmitis rates almost tenfold before and after using intracameral gentamicin. But the real landmark study came in 2007, CRS endophthalmitis study group, where they reported a statistically significant reduction in endophthalmitis cases over a sample size of 16,000 odd cases. And till date, this has been the only prospective randomized controlled trial. Then there was a series of papers which were published as mentioned in this table and more. But I would like to draw your attention to the last two, which were published from India, Arvind Eye Hospital, which used intracameral moxifloxacin, and they had a very high number of cases as well, both reporting almost 3 to 4-fold reduction in postoperative endophthalmitis. But herein lies the catch. Apart from the ESCRS study, all the other studies were retrospective in nature. Why that is important, we'll just come to it in a bit. Before that, a special mention for two cases. This was again a study out of Arvind Eye Hospital, which was published in 2019. They reported 2 million consecutive cataract surgeries series, where not only did the rates of the endophthalmitis reduce, but they also reported a reduced rate of endophthalmitis in patients who had intraoperative complications like PCR. The other study I want to talk about is one which came out of LV Prasad Eye Hospital. They reported a reduction in end-off rates in about 66,000 cases, although it was not statistically significant. However, they reported that the group receiving ICABs showed less severe signs and symptoms and better prognosis compared to the group not taking ICABs. Now, all of this is evidence in favor of ICAB, but there are still certain limitations of this published data, which a lot of people who are not using intracameral antibiotics generally use to justify their decisions. Now, what are these publications? First of all, there is lack of level 1 evidence, which is to say that apart from the ESCRS study, there is no prospective randomized controlled trials that have been published in support of intracameral antibiotics. Most of the studies are retrospective. Now, because in endophthalmitis is such a rare occurrence, you need a large number of cases, and these can only happen over a large period of time, like 4 to 5 years. And a lot of people say that the reduction in rates of endophthalmitis reported over extended periods of time could also be because of better practices over this period of time. Then, of course, there is the huge elephant in the room about TARS and causing other toxic reactions to the macula and the endothelium, which are a big deterrent for a lot of people to start using intracameral antibiotics. And the fear of causing resistance. This is a very interesting one because a lot of time people say that this is more theoretical. However, I managed to lay my hands on this antibiogram of as recent as May of this year. And as you can see, the gram-positive cocci isolated from the vitreous tap turned out to be resistant to all the 3 currently used intracameral antibiotics. So if this patient had even been given an intracameral antibiotic, he would still have landed up in with an endophthalmitis. Now, coming to the myths about ICAB. For this, I did something very interesting. I created a spot poll on these WhatsApp groups. I sent this poll on 3 different groups. One was a local group of a tier 2 city where I'm based. Second was a pan-India group. And third was a group which is my alumni group. We are all trained from a common institute. And one would assume that coming from a common institute, everyone would generally follow similar practices. However, the results were rather interesting. I had 2 questions on the poll. A, do you use intracameral antibiotics? And if no, then what is the reason? I got a total of 92 responses, out of which almost 50% of people was routinely using ICABs. 44% said that they were not using ICABs, and 5% said they were using it only for high-risk cases. Even the responses were quite flowery and quite extreme. It ranged from someone who had a couple of TARS cases 9 years back and hadn't used ICABs since then, to someone who has not operated a single case without using ICABs, to even people who say that they can't get sleep at night if they don't use intracameral antibiotics after the cataract surgery. And what does the literature say about the usage? In India, this report published last year, Deepak sir was also one of the authors here, says that 58% of the Indian ophthalmologists were using intracameral antibiotics, while 42% were still not. When we asked the reason for not using, the main reason given by most of them was they did not want to cause toxic reaction. And that is the single largest barrier that I feel which prevents people from actually adopting, including myself, intracameral antibiotics. Quickly, just to sum up what the myths are or what the people think about ICABs and what the facts state. A lot of people are not sure about the efficacy. However, there is tons of data which has debunked that and has shown that it is actually very efficient and effective. Cost used to be prohibitive, not anymore. Availability used to be a problem, not anymore. Too scared of TAS, yes, that is true. But if you consider having one endophthalmitis patient in return for 3 or 4 TAS patients, I think it's a cost-benefit ratio which tilts in favor of the intracameral antibiotics. There are certain people who just don't want to change the way they work, and they say there's no specific reason. Unfortunately, even God can't help them. So that is about it, and I'll be happy to discuss it with the panel. And I would actually like to know what everyone's practices are as far as intracameral antibiotic usage.
Dr. Varun, since you are the speaker and it's a divided house, as you have shown from the survey also, I'm sure here also it will be a divided house. As a speaker, since you have done so much of research on what all the studies are and what everybody is saying, what would you recommend and what do you do? Let's start with you.
Ma'am, without doubt, intracameral antibiotics should be used. Like I said, personally, before I started doing research for this topic, my experience was one DSEC done back at Narayana when a patient was injected intracameral moxifloxacin and the patient landed up with the corneal decompensation. But as I said, those are the outliers, and the cost-benefit ratio with intracameral antibiotics is way too much in favor of using them rather than not using them. And I myself am planning to now start getting in touch with the people who have those pre-filled syringes. That would be the ideal, because the whole practice of loading Vigamox in the OT and diluting by your assistant, that is where the errors generally occur. The pre-filled syringes are way better and way more convenient. Although I don't use it right now as of today, but within a couple of weeks, I'm definitely going to start using.
Dr.
I would like to say,
Ji, sir.
yeah, Dr. Mani.
Dr. Kharbanda, do you put any antibiotic in your solution?
No, sir. No, sir. No, sir. That has been proved to be ineffective, sir. There is no data supporting the use of that because the concentrations reached in the anterior chamber and the duration that they stay in the anterior chamber are both below the MIC, sir. That's basically of no use.
So basically, you are not using any antibiotic in the fluid and you are talking about intracameral.
Only intracameral at the end of the injection, end of the surgery, sir. Not in the irrigating fluid.
Okay.
So here I would like to say that if I talk about myself, I do not use intracameral antibiotics. But recently we were a part of one study, which was the lead was Dr. Namrata Sharma from AIIMS, and there were multiple centers in it, and we all and the retrospective data was analyzed. And this is going to be the largest study all over the world. I don't remember the exact number of cases, but somewhere around it's larger than whatever is available in the whole world, and the results have been analyzed and it has been accepted also for publication in ophthalmology, and that study says that intracameral antibiotics are better. So we were a site which is not using, but there were multiple sites. Some were using, some were not using.
It's about barriers, ma'am. The barriers are very strong and mostly they're in the mind because the data is absolutely clear-cut in favor of ICABs. Dr. Matthew might want to add something.
So I agree that worry about TAS is the main drawback. But today we have drugs which are manufactured by reputed companies, which are for the specific purpose of intracameral use at the end of surgery. So the other issues which brought up the fear of TAS were the fact that it was compounding, you were using an eye drop for intracameral use, all those kind of things. But now these are specifically made for intracameral use at the end of surgery for the specific purpose of endophthalmitis prophylaxis. So I think our TAS worries should go down. Second, if we look at guidelines, including our AIOS guidelines, it is talking, I think, in terms of looking at intracameral antibiotic at the end of surgery. Now, it is possible that a future endophthalmitis case, if it goes to court, there could be somebody who says that, the non-usage of an intracameral is what led to this problem. And that would make us also vulnerable. Today, I don't think anybody proceeds to cataract surgery without preoperative installation of povidone-iodine. Similarly, I think soon it should become a mandatory practice that all of us should have IC some form of intracameral antibiotic at the end of surgery.
Are you using it, sir? Are you using
Yes.
intracameral antibiotics routinely?
Yes. Now
So
about 8-9 years
let's-
I've been using.
Okay. So let's hear from real time from the operation theater, Dr. Shashank Kumar Srivastav, sir. Are you using intracameral
Dr. Varun,
antibiotic?
may I ask you one question, simple question from you?
Yes, sir, please.
Do you recommend the hydration of the wound with the antibiotic also?
No, sir. No, sir.
Why some of the surgeons I have seen
Okay.
that they just
There is-
hydrate the wound with the
सर एक हिंदी में कहावत है सर, जन्नत की हकीकत हमें मालूम है लेकिन दिल बहलाने के लिए गालिब ख्याल अच्छा है। ये सारी चीजें सर डेटा बैक नहीं है सर, ये एविडेंस बेस्ड नहीं है। These are not evidence based.
That's right.
These are just
One
to
is we can, yeah, as Varun says, one is that what individual surgeons may be doing, but overall, the message has to be what is data backed and what
data
what
backed
is
and evidence
recommended.
based. Yes, sir. This is not evidence
Dr.
based.
Yeah, Dr. Shashank, you're about to
Yes,
start
ma'am.
your surgery, so could you about
I don't
intracameral
use any
antibiotics?
intracameral. I don't use any intracameral. मैम एक चीज का मैं ख्याल रखता हूँ ओटी में, क्योंकि जो हम लोग जो ये बॉटल जो यूज करते हैं, क्योंकि अब इन्फेक्शन का सोर्स या तो विस्कोएलास्टिक है या जो फ्लूइड हम यूज करते हैं, तो मैं एक चीज है कि मैं कोलेस्ट्रॉल बॉटल यूज करता हूँ और उसमें मैं एयर वगैरह उससे देयर आर मोर चांसेस। उन बॉटल्स को मैंने 2-3 दिन तक, जैसे हमारे उसमें ओटी के साइड एरिया मैंने रखवा दिया था, और उसमें मैंने देखा उसमें फंगल ग्रोथ कुछ में आ गई थी, और खास जिसमें ऐसे टाइम में मतलब मैंने ग्लास बॉटल यूज किया और उसमें एयर कैबो डाला, और फिर उसको मैंने देखा 24 से 48 घंटे 72 घंटे के बाद में, तो उसमें फंगल ग्रोथ थी। तो मेरा ख्याल एक सबसे बड़ा इंपॉर्टेंट कॉज यही है कि जो फ्लूइड वगैरह यूज करते हैं, इसका डायरेक्ट ओटी कनेक्शन अगर ना हो तो ज्यादा अच्छा है। तो कोलेप्सिबल बॉटल आई थिंक ठीक होती है, एंड इंट्राकैमरल आई डोंट यूज, आई मीन नो लॉजिक।
Thank you. So, if anybody wants to say anything else, otherwise we close the session. Any other comments?
Ma'am, I also don't use intracameral antibiotic, despite all the discussions I have participated in. And if this becomes the criteria of making a person culprit for a possible endophthalmitis, this will be really unfair. But if it has to happen, it will happen. There are many things which
whether
are
you
happening.
use the antibiotic or not, whether you use the antibiotic, but documented
As of now,
anybody
it is
can see
not
in the
there in
board.
the recommendations of AIOS. But yes, as Dr. Matthew said, that if there is something in the court of law, then the lawyers come up with the recommendations, and they don't.
Medical legal
that's
issues.
what they tend to follow.
The medical
that will be a really very unfortunate situation, because actually probably we are looking away from the basic precautions rather than the surface thing.
No, sir. So, sir, if I could join in for just a minute, medical legal implications happen when the prescribed guidelines are not followed. Now, the prescribed guidelines say that the area has to be cleaned by povidone iodine. You have to do the surgery in a particular way. You have to sterilize in a particular way. However, intracameral antibiotics have not been included. Povidone iodine, etc., has been included. Why is intracameral antibiotic not included? A, there is an ethical issue. आप randomized control trial नहीं कर सकते. If it has shown to have benefit, you cannot compare two groups giving a benefit causing drug and not benefit causing drug. Other thing, it takes a long time because the occurrence is 0.03 to 0.07%. You need to take a lot of time and a lot of cases, and it is multivariable, sir. Out of the 1 million cases that we have and we report 5 endophthalmitis, we cannot pinpoint that those 5 were because of non-usage of ICAB. Maybe the staff nurse did not clean that particular case properly. Maybe the patient had a cold properly. So that is why there is this barrier where none of the organizations, see, ESCRS did it. So they had level 1 evidence there. It is a part of their guidelines. You can be sued in Europe for not using intracameral antibiotics. Unfortunately, India and America and the rest of the world don't have their own level 1 evidence backing this up. But I'm sure the people who are in charge will find a way to get around this barrier, because, sir, there is too much of circumstantial evidence and too much of scientific data, statistically significant or not, which supports that an intracameral antibiotic is the way forward. मैं खुद नहीं use करता, sir, but when I started doing research, I realized that there were a lot of aspects that I did not know myself.
I will tell you, Dr. Kharbanda, when I presented on A-scan in one of the meetings, and I found that immersion, this thing is much better than contact biometry, and the whole world accepts it. After presentation, I shifted to immersion, and I found that my results have gone down. And I shifted back to contact. Because contact in my hand with my factors is working and giving
Absolutely.
reproducible results. So
Absolutely.
that does not mean that you should stop thinking and you stop
Absolutely.
looking at what you're seeing on the ground. And if your protocol legally stops you away from doing this basic thing, then I think it will be not good.
Not good. Fair enough, sir. It is
Or
obviously
I
personalized.
give you one
Totally
more. I give you one more example. The whole world says that applanation tonometry is better than non-contact tonometry. I did comparison of 10 patients of non-contact tonometry findings with applanation tonometry findings, and the difference was statistically not significant. I shifted away. I stopped doing this thing, applanation tonometry at all. And I have heard that glaucoma people are even now not doing that pachymetry correction also. So that is how you see you should be free to look into learn new things. Otherwise, you will be bound down. That is what is the
it's a totally personal choice, sir. It's a totally personal choice, and everyone's
you
hand is
can,
different. Yes,
as
sir.
a society, you can give guidelines. Yeah, these are the studies which are favoring use of intracameral antibiotic, and we recommend that you use antibiotic. There was a presentation by Dr. Lalit Verma here in Kanpur, and when he said he faced this dilemma of issuing a AIOS guideline for members of AIOS. Then he said, we have top level institutes with world-class facilities, and we have just ground level people who have only basic facilities. How to make a guideline which is applicable to all the levels is a great challenge for an organization like AIOS. So whenever, like today we talked about modular OT. We talked about class B sterilizer. We also, this is only a part of the picture. When you start planning OT from a level of, say, LV Prasad or Shingva Netralaya or maybe Narayan Netralaya, you're talking at a different level of a thing. But when you're talking of making an OT for Dr. Kharbanda or Dr. Chaturvedi or maybe Dr. Dharmen Nath also, then we talk of different level. And therefore, and you can't say that this level is inferior than this as far as the outcome is concerned. So just by saying that you have these facilities, you become a better surgical outfit will be actually going against the common ophthalmologists. So I think we have discussed very nice.
Thank you so much, everybody. And the idea of this webinar was to make everybody knowledgeable about the best protocols for infection control and how much we can follow in our own setups. The maximum that we could follow in our own setups would be good for all of us. Everything, as Dr. Malesar said, may not be possible, but whatever maximum we could do would always be helpful and useful. So thank you to all the speakers for your insightful talks, and thank you to the panelists for your comments and your suggestions, and we will soon meet again.
Thank you, ma'am.
Thank you, Dr. Mehta, for arranging such a nice program.
Thank you.
Thank you.
Thank you.
And thank you, Dr. Kurian and Dr. Kharbanda.